I'm going to be talking about the follow-up of women with gynecological cancer, and in particular the use of PAP smears following diagnosis and treatment of uterine and cervical cancer. This is an important area because follow-up has not really been studied. There are no randomized prospective trials, and so we have to rely on retrospective cohort data on which to make a recommendation. It is also important because current guidelines are confusing, and so if we can summarize these, hopefully this will be of value to the listener. First of all, PAP smears in the follow-up of endometrial cancer. There are a couple of guidelines which suggest that this should be done every 3 to 6 months and continued anything up to 5 years. There is, however, no information to support this, and there is now a reasonable meta-analysis to suggest that there is no need for routine cytology in the follow-up of patients with endometrial cancer. Furthermore, we do not believe that there is a major role using cytology, using a PAP test in the symptomatic woman who has a recurrence. Obviously, biopsy is the most important aspect of this, and the histology needs to be confirmed. So in summary, abandon PAP smears in the follow-up of your patients with uterine cancer. The second issue, however, is equally important because I think we can recommend that PAP smears are an integral part of the follow-up of women with cervix cancer. And indeed, HPV DNA testing may be the way to go in the future. The issue around routine cytology for the follow-up of women with cervix cancer is a difficult one because we don't know how frequently we should be doing this, and we don't know exactly what the positive and negative predictive value of these tests are. However, we know in clinical practice that PAP smears are useful, and we know that a negative result will give us some confidence in the absence of disease, particularly epithelial disease. What we should recommend, however, that in women who have radiation treatment, PAP smears should not be used because of the very high number of false positives. The data on using high-risk HPV DNA is encouraging. There are only a couple of papers to support this so far, and I think more study is required, but inevitably this will end up as probably the more important test, either alone or in conjunction with cytology.